to speak in 7 minutes about the current status in cardiovascular diseases, how we cope, how we anticipate the future as a heart association, the Israeli Heart Association, and what current things we are doing right now, and all of this going to be in 7 minutes. So as an obliged cardiologist, I will try to do it just to make sure that okay. Oh, you see it? Okay, great. So I know that everybody is thinking rightfully from his point of view that what he's presenting is the most important discipline, but I think that we are not going to argue too much about the cardiovascular as a major issue in all aspects. Actually, all of the disciplines are heavily involved with us as well. And I will take you just to show you the current status to the kitchen of my Heart Institute in Hadassah Medical Center of Jerusalem. And we'll try with this heavy metal rock and roll show, which I will explain to you in a minute. But this one case that we did may shed some light on what we are doing, because now the cath lab actually became like a surgical suits or a theater suites, and there we are. So this is a lady who came with infective endocarditis, okay, and she had a mycotic aneurysm of the aorta, and she had practically a pending rupture of the aorta, which is probably the most sure way to die, and to die very quickly. The surgical risk was astronomical. On conservative scales, it was 50 to 60%, etc., etc. She had also had aortic regurgitation because the first origin of the infection was in the aortic valve. So she had this endocarditis with a mycotic aneurysm, and the decision was to take a little bit unconservative measure and to do a stent to the aorta, trying to make her alive, at least for the surgery that was a definitive procedure. So what you see is what you see here is the first step that we did. We put a stent by our interventional team, ran by Dr. Planner, and we put a stent in the aorta. This is already something a little bit unusual, because now cardiologists, interventional cardiologists, are acting more and more in the vascular area. That's why we call it a cardiovascular medicine and not only cardiology medicine. So we put the stent, and the sealing was fantastic, and there was no pending rupture whatsoever, but the patients crushed and burned on the table. The anesthesiologist started to give her mega doses of adrenaline, etc., etc. And there was done the second, a little bit unheard of decision, and the idea was to put a TAVI on the aortic valve. Now, you have to bear in mind that aortic regurgitation is not the indication for TAVI. You don't have also the calcium there. This is a very unusual situation, but the idea was, to try to get some time, maybe hours, of the patients to be alive. And the second metal, you see what I'm showing here? And the second metal, we need some technology to the conference next time. So the second procedure was done on the aortic valve, and she got both stents in the aorta and the TAVI in the aortic valve. Now everybody was waiting for the boom. The next day she was extubated. The second day the kidney came back to normal. She was discharged 10 days later, 14 days later, something like this. This is a year later, okay, with this lady. So what happened is that a major surgery, cardiovascular surgery, that was needed to have a procedure to the aorta and the aortic valve replacement, ended up in the cath lab in a very dramatic decisions, and this is one example. This is another example, and you can see this reconstruction of the aorta of this patient, which basically can be titled as a horrible picture. And he had an aneurysm of 63 millimeters on the aortic arch. Now, any surgeon, and I don't know if Professor Stanek is still here, will tell you This is a clear indication of aneurysm in the aortic arch. This is a type A kind of equivalent to dissection, etc., etc. This is going to surgery without any other hesitation. So that is fine, but what you do if the patient is extremely high risk and cannot have this, one of the biggest and most extensive surgeries that can be in cardiovascular. So we decided to go and to do this nexus implantation. This is a stent to the aortic arch, again, a modulatory stent that you put in couple of frames that you put it in the cath lab itself. This was designed and originally planned in Hadassah interventional cardiology team. Already more than 150 cases were done around the world, and we had 4 cases in Israel. 3 of them the first 3 were in Hadassah. This is how you plan it before. You do a 3D printing. And as you can see, this 3D printing is very similar to what the patient really has, which helps you actually doing the procedure literally twice, one on the 3D printing and one in the actual life. This is a patient itself. You can see the reconstruction, and there is a lot of imaging with the acquisition that you do during the procedure itself. And again, this is something which is major, and the patient can be discharged home in a very few days. Now, Dr. Sternik rightfully pointed out about the LVAD. Myself, as a heart failure cardiologist, can tell you, and I think that he will support it, the surgeons will support it. LVADs are basically a heart failure cardiologist business, in the meaning that you have to bring the right patient at the right time to this procedure. From the surgical procedure point of view, this is not something which is unbelievable done in the surgical theaters. They are doing much more complex procedure, but the main issue is to choose the time and the patient for this procedure. And this is how it's done with the two cannulas that already been mentioned before, and you do the LVAD implantation. So we treat coronaries, we treat valves, and we treat the myocardium itself. Now, this is a new kid in the block. The whole new catheters, percutaneous catheters, either repairing or replacing valves. What you can see here is edge-to-edge leaflets coaptation that you do with a catheter-based, and you actually may save the patient a replacement of the valve itself. It's originally it's planned for patients who had extremely high risk of doing MVR, for example, a mitral valve replacement, and you do it in the cath lab itself. You have the imaging, which is fantastic. As you can see here, you know exactly where you are. You have to have a very sophisticated imaging, and the imaging did a huge leap forward as well with the catheters and the procedures. Without them, you can't do it. Actually, the echo guys and the imaging cardiology people are the instructions of the implanters themselves. This is another area, and this is electrophysiology. We are done practically with giving antiarrhythmic medications. We gave you toxins to actually to solve some arrhythmia, etc., etc. This is literally over, almost over. Maybe still some beta blockers and amiodarone, but other than that, you can use electrical systems. You can use electrical mapping, as you can see in the cath lab, and doing this electrophysiology mapping. You find the electrical circuit, and you know exactly where to interfere and where to do the burning. It can be either heat or cold treating. Now there are many other ideas of physical triggers that you can use to actually eliminate and save and complete the arrhythmia as a whole. It can be either a life-threatening arrhythmia like ventricular tachycardia. It can be atrial fibrillation, which bothers the patients and is associated with a lot of morbidity and mortality. A lot of catheters, electrical catheters are implanted. The procedures may take 8 hours, 10 hours, and sometimes 12 hours. Sometimes you obviously need the general anesthesia, but you can cure the patients in so many arrhythmia, and this is a whole revolution that we are doing in cardiology. What is expected? What we expect is obviously an increasing number of patients. Now it's very nice to talk about the COVID, post-COVID cardiovascular, but obviously aging, et cetera, et cetera. The patients are much more complex, had a lot of comorbidities, and I guess that what we called miniaturization and minimization of the procedures is going to continue and increase the load on the interventional cardiologist rather than on the surgeons. That said, I think that we learn in a good way mostly that we need a hybrid approach. I can tell you now that the patients are usually treated in what is called the heart teams, which is a collection of cardiologists, usually interventional cardiologists, imagers, echo, MRI, CTs, et cetera, and cardiovascular surgeons. We have to work as a team, and this is part of what we are trying to do as a union to push this concept, and I think that in Israel it's done pretty nice in most of the places. The technology did bring a lot of other problems that we did not anticipate. For example, about half of the hospitals in Israel, and actually excellent cardiology units, cannot perform TAVI, cannot perform percutaneous aortic valve replacement. Now, you have to bear in mind that now young cardiologist, when he wants to be interventional cardiologist, he almost doesn't look about on the coronaries. He looks at the structural issue. He looks on valves. He looks on including the appendage, on ASD closures, et cetera. And he's looking for a place that he can has his fellowship and be exposed to this. Now, if you need a cardiovascular surgery on site, and this hospital doesn't have one, then he has kind of a crippled cardiology service, although the cardiology service can be an excellent one. So this creates a little bit imbalance between the departments, and especially on the small hospitals and the peripheral ones, and we are trying to bridge in between. The last one is the patient education, and I think that this is vital to all of us, to remember that behind any technology still you can need to look at the eyes of the patient and the family, and there is no way that you cannot explain in a very simple words and a very empathic way what you are going to do, and there is no patient who cannot understand you. It depends only on us. Thank you very much.